Hi, welcome to part 4 in my video series on C. diff infection. In this video, we will be talking about Clostridium difficile recurrence and what you can do about it. If you're interested in finding out what C. diff is, where it is in the environment, who is asymptomatically colonized, how you can prevent it, how we diagnose it, and how we treat it, check out videos 1 through 3 of this series. But in this video, we're specifically talking about recurrence and treatment options. I'm Dr. Katrina Coulter. I'm an infectious disease specialist, and I make educational health videos with a focus on the microbiome. Just a reminder, these are for educational purposes only and not to be taken as medical advice. C. diff recurrence is a big problem. We estimate it costs about $10,000 per person per year in the United States. And the percentage of recurrence is not great. 10 to 25% of people that have an initial episode of a C. diff infection will then go on to relapse and have recurrent C. diff. And the highest risk occurs within 1 week after stopping the treatment for the initial episode. The human intestinal microflora is the main protector against getting C. diff. And so when one gets that, this is very disrupted, and it takes a long time to go back to the state where it's healthy and it's diverse and it can ward off infectious pathogens. Unfortunately, the statistics get even worse. If you've had 2 or more recurrences of C. diff, your risk of getting it again is 65%. That's really high. So every time that it recurs, your chances of it recurring again are higher and higher because the microbiome is further and further disrupted. That doesn't mean we don't have any treatment options. Traditionally, we have used Fecal Microbiota Transplant, or FMT, to treat recurrences in C. diff, especially if you've had 2 or more. That's when we take the stool from a healthy donor and we transplant it into a person that has C. diff. And this can either be done with an NG tube down the nose, enema, or a colonoscopy, or now we have it available in pill format. This is old technology, not something new that we just came up with. This was practiced over 1,000 years ago in ancient Chinese medicine, and it was used to treat infectious diarrheas and food poisoning. In the 17th century, veterinarians used this method in animals, and then in 1958, we did it for the first time in the United States. Part of the problem was that it was never FDA approved. And so although we knew it was very effective with an 80 to 100% cure rate and prevention of recurrent episodes, we just had this concern that there could be transmission of other infections through this donor stool, or that someone could have an autoimmune reaction. So unfortunately, we no longer have the open biome. This is where many people sourced donor stool to transplant into patients. So fecal microbiota transplants are no longer being performed by gastroenterologists. Instead, here in 2026, or at least of the first part of 2026 when this video is being made, we do have a couple of FDA approved options to give patients this treatment that was very efficacious. The first one is an enema called Prebiotics, and this is done in the outpatient setting, usually with a nurse coming to the patient's house to administer the enema. This one has a recurrence rate of about 29 to 30%. The other option is an oral formulation called Voust, and this is produced by Nestle, which is sort of ironic. This is a pill, and it includes human microbiome as well as some prebiotics. And this one has a greater efficacy in preventing recurrence, only seeing about 12% recurrence. So these 2 options are now available as fecal microbiota transplant. You need to talk to your healthcare provider if you have further questions about this or you think you would be a candidate. There are other options we traditionally have used the oral antibiotic vancomycin, usually in a longer course than what we would treat an initial infection, and sometimes in pulsed or tapered courses. And I've done this quite a bit in my career with some pretty good efficacy. And with the pulse doses, the thought is that we're kind of weaning the microbiome off of the medication while we're allowing it to reestablish itself. The same can be done with a medication called fidaxomicin. That is our latest antibiotic on the market to treat primary and recurrent C. diff. And this one is pretty effective as well. It's just a little bit newer, so it's not been used as often as the oral vancomycin. Sometimes, as clinicians, we will also use oral vancomycin as a prophylaxis, meaning somebody does not have diarrhea, but they've had a history of C. diff, and they are very high risk for a relapse of C. diff when they get an antibiotic course for whatever reason, meaning they're immunocompromised or they have some other reason why we feel they are very high risk for getting C. diff. And so sometimes we'll use oral vancomycin, not in the full dose, but in a smaller dose as the patient takes their other systemic antibiotic to try to protect their microbiome. Now, people frequently ask about probiotics and prebiotics and postbiotics as prevention. Unfortunately, the studies on probiotics are all over the place, and so the data is really inconclusive. When you do a meta-analysis, there may be a small benefit in primary prevention, meaning preventing first episode of C. diff with certain probiotic combinations, certain combinations. There's a lactobacillus one, and then there's a Saccharomyces one. The prebiotics and the postbiotics have been studied in animal models where there's been some promise, but those have not translated into human models that have actually worked. And the reason I suspect this is not working is because when we think about the microbiome, there are trillions of microbes there that are interacting and all playing a specific role. They're competing for resources. Some microbes are producing metabolites that are inhibiting more pathogenic microbes. And then, of course, they're producing their metabolites like short-chain fatty acids that are helping rebuild that intestinal wall. So trying to isolate just one piece of that is not successful. You really need the whole complex biological process, and that's what happens when we do the fecal microbiota transplant, is we're transplanting a lot of different species into the impaired microbiome. Thank you for joining me in this deep dive into C. diff. I really hope that you found it helpful and got some useful information about it. Please subscribe to the channel so you don't miss any further videos on infectious disease and the microbiome. And if you are interested in working with me to restore your microbiome, come over to my website at www.katrinacoultermd.com. I will see you next time. Thank you for watching.